Hello, my name is Lina Ciccone, and today I will be presenting my collaboration and leadership reflection video for NURS FPX 4010, Leading People, Processes, and Organizations in Intraprofessional Practice. During this video, I will present all competencies for the assessment. I plan to reflect on an interdisciplinary collaboration experience, noting in ways in which it was successful and unsuccessful in achieving the desired outcomes. Citing supportive evidence from the literature to help identify best practices, leadership strategies that would help improve an interdisciplinary team's ability to achieve its goals. By citing at least one author from the literature, I will also identify best practices and interdisciplinary collaboration strategies to help the team achieve its goals and work together. I will also communicate in a professional manner and easily audible and use proper grammar. I've been a nurse for about a year and a half, spending the entirety of this time working in a 24-bed intermediate care unit. The hospital is in close proximity to two long-term care facilities that care for patients who are ventilator dependent. A large portion of these patients have suffered from anoxic brain injuries, leaving them with the inability to communicate or express their wants or needs. So when they present to the hospital, we have to assess them and treat them based on the vitals, labs, and other indicators to help explain what is wrong with the patient and create a appropriate care plan. This is not always the case, and some patients have the ability to answer yes or no, and some patients have all mental faculties about them and can express their wants or needs. In this scenario, I will discuss a patient I recently had who is one of that small population. This patient is a 37-year-old male who suffered a gunshot wound to the spine, leaving him paralyzed from the neck down. He had a tracheostomy for respiratory support as well as a PEG tube for nutritional support. He was a very thin man with an extensive number of deep tissue injuries, some as deep as the bone. His extremities were contracted and atrophied from being bedbound for many years. He was able to communicate with the medical staff and express his needs, in which would mainly consist of pain medication and the want to eat and drink. Knowing his swallow was not safe and he was extremely high risk for aspiration, he did not care. He still wanted to eat and drink. He would often say, "All I want is a cheeseburger and then let me die." This statement was made to nursing staff and medical doctors alike. Always the same wants, always the same ending. This raised many red flags to the staff, wondering if he was being cared for in the way he wished, or if we were caring for him beyond his wishes. During this time spent with the patient, he presented as a full code. All life-saving measures would be done if he were to go into cardiac or respiratory arrest. That being said, if he did not want these measures, then his code status would be inappropriate. When doing a nursing assessment on the patient, he was able to answer all orientation questions appropriately. He knew where he was, what the date was, why he was in the hospital, how he became bedbound and ventilator dependent. So from a nursing standpoint, he had the capacity to give or decline consent. When he expressed many times the want to die to the nursing staff, we notified the hospitalist assigned to the patient and expressed concerns about code status and the patient's rights to make decisions about his care. This patient was consistent in his statements, his wants, and his needs. This being such a bizarre case, the doctors were uncomfortable with creating a hospice or comfort care plan for this patient. The doctor requested a psychological evaluation to determine if the patient was within mental capacity to be making such a decision, along with ruling out if the patient had severe depression or suicidal ideations. After a psychologist made their independent evaluation, they wrote in their note everything but did not say that the patient had capacity, but would imply this. This left the hospitalist still uncomfortable with any changes in his current care plan. The following day, there was a change of hands and a new physician was taking on the case. With an effective handoff and great concerns expressed to him about the patient's care plan, the conversation continued. The oncoming doctor consulted the patient's legal decision maker, who was his sister, to determine if the family's insight on the situation. The patient's sister was the point of contact, as he never was married and his children were too young to make such a decision. She informed the doctors the decision is whatever he wants it to be, and they would respect that. The question still stood, what is the right decision? The doctor requested a consult with the ethics committee to determine what appropriate actions are. At the time of the ethics consult, me being the primary nurse assigned to this patient, I was questioned about how I felt and if, in my assessment, the patient was requesting an appropriate outcome, thus raising the question, are we withholding the patient's right to die? During chart review of the patient, they agreed that it appeared the patient has capacity. In evaluating the effectiveness of a clinical ethics committee, a systematic review discussed much of what ethics committees' duties are when they are consulted on a case, but they are found to be difficult to create a hard outline due to many ethical and moral variabilities. Although the number of publications concerned in clinical ethics committees is high, their actual effectiveness in clinical practice is yet to be clarified. With so many people involved, handing off between two physicians during this time, the ethics nurse documented this Virginia law in the note. A single physician may at any time upon a person's evaluation determine that the patient who has previously been determined incapable of making an informed decision is now capable of making an informed decision, provided such determination set forth in writing. This left the final say back on the physician in charge of the patient's care. Fortunately, by this time, the patient's acute reasoning for being inpatient had been resolved, and he was sent back to the long-term care facility, still with the same code status and no major changes to his long-term care plan. The right to die is a very controversial one many people avoid due to their own ethical biases. Although depression can be diagnosed and treated in patients with serious medical illnesses after optimizing medical and psychiatric treatment and determining if the patient's competent to make the medical decision, it may be appropriate to honor the patient's desire to die. Shapiro's evaluating decision-making capacity and supports this in stating, patients who have been deemed competent to make ethical decisions can refuse and seek medical-specific treatment. All medical treatment from healthcare practices. The term competent means the patient understands that refusing to accept treatment will result in eventual death. This is supported in Minchoa's article, Euthanasia, Ethical Challenges of Shift Form, The Right to Die, to Objective Decision. It may be noted that the basic idea behind mercy killings, euthanasia, is to reduce misery and not enhance it by such techniques as withholding respiratory support, tube feedings, intravenous fluids, and medications, followed by an impassive euthanasia, which is perceived as a safe method although actually it is against the spirit of euthanasia. As such, passive and active euthanasia are directed to the same goals causing death. The distinction between passive and active euthanasia is unnecessary. We often see passive euthanasia during the end of life or comfort care, ensuring the patient has no pain during this time and their end of life experience. These situations are often made acceptable when the patient is of senior population with advanced stage dementia or cancers, not when the patient is young and sound of mind. We do not accept withdrawing care as a part of a care plan if the patient still has a life to live. But you can argue whether it is living a life when you are in your 30s, bedbound in a ventilator, living in a skilled nursing facility. It is our duty as healthcare providers to ensure autonomy and justice to be provided to these patients, even if it means allowing them to make the decisions to withdraw their own care. I feel in this situation, communication with the patient and appropriate decision-making could have been handled better, and autonomy should have been put back into the hands of the patient, giving the patient the ability to make his own decisions on his care plan and long-term care goals. With no chance of recovery due to the injuries he had sustained, we could ask the question, is this what he would have wanted in the first place? Non-maleficence is taught to do no harm. We are causing no more harm by allowing him to withdraw a ventilator. These are valid questions that must sit with and understand it's not what we want as healthcare providers, but what they want as the patient. We do not push care onto a patient with extensive cancer, encourage them to enjoy the short time they have and create memories with their families. There are still improvements to be made within the ethics committee and communications, with teams providing direct care with education. This can help better interdisciplinary professional communications, and thus concludes my reflection video for FPX 4010.